Hi, everyone. Thank you all for joining us today. My name is Scott Burns, and I'm the CEO here at NICHQ, the National Institute for Children's Health Quality. I am here with my colleague, Dr. Stacy Scott, who will be co-facilitating this webinar with me. And we have two wonderful speakers, Dr. Art James and Ms. Denise Evans, who are the real features of today's webinar, both champions in pursuing health equity at the state and community level. Each will be presenting on successfully pursuing health equity, and they'll be introduced more fully before they present in a few minutes. Today's webinar is the second in a series on health equity. In the spring, we shared our first webinar, which was focused on implicit bias and what we can all do to address it and help eliminate disparities. This webinar is the next step in that conversation, moving from individual actions to programmatic change. Over the next hour, we will address the following objectives: review key takeaways from the previous webinar on implicit bias, situate the conversation with historic context of equity and infant mortality, describe successful programs that have addressed health equity and review lessons learned, and share strategies that programs and organizations can use to champion health equity in their work. Please note that we'll be sharing the recorded webinar after the call. Before we jump in, I want to provide some quick background on NICHQ and why we are passionate about this topic. NICHQ is a nonprofit organization that for 20 years has solely focused on driving dramatic changes in the complex issues facing children's health. Here you see our mission and vision. At the heart of what motivates us is the belief that children and families deserve better systems and supports so that every child achieves her or his optimal health. Because of this belief, addressing social determinants of health and eliminating health disparities is central to our mission. The necessity of building health equity to improve population health and children's health is illustrated in every one of our improvement initiatives, from reducing sleep-related infant deaths to empowering parents to be advocates for their children's social and emotional health. I am now going to turn this over to Stacy, who will quickly review the key takeaways from our previous webinar on implicit bias, and we're excited to be continuing this conversation with all of you today. Stacy?
Thanks, Scott, and thank you all for joining us today. Before we jump in, I want to ground our work by reviewing the definitions of health equity from Robert Wood Johnson's Foundation, which we shared on our last webinar. Health equity means that everyone has a fair and just opportunity to be healthier. This requires removing obstacles to health such as poverty, discrimination, and their consequences, including powerlessness, lack of access to good jobs, fair pay, quality education and housing, safe environments, and health care. The program and strategies you will learn about today are focused on achieving health equity, on removing these obstacles so that all children can have the opportunity to be healthy. This programmatic work is critical for driving national change, especially when combined with individual efforts to eliminate bias. Before we move into the organizational and programmatic improvement examples, we want to briefly review what those individual efforts look like as discussed on the spring webinar. One thing we can do to champion health equity is to recognize our implicit biases and address them. Implicit bias is the unconscious stereotypes and attitudes that influence our actions and decisions. Our brain recognizes patterns based on what we see and experience. For example, in our environment, we develop subconscious neural connections that influence our actions. Implicit bias is activated quickly and unknowingly by situation cues, for example, a person's skin color or accent, silently exerting its influence on perceptions, memories, and behavior. It operates without a person's intent or awareness. Controlling is not a straightforward matter. It justifies unfair treatment that can have long-term negative impact on the targeted physical and mental health. Recognizing and addressing biases is a critical step towards eliminating disparities, and achieving health equity. And it's something every one of us can work on. And every healthcare professional learned how to address these biases. This would take us a long way toward achieving health equity. Those efforts are important, but they can only go so far when compared against the continued adverse effects of structural racism. We need to confront structural racism. We need to recognize its pervasive effects of our systems and the health of minority families and commit to real systems change. With that, I would like to introduce our first speaker, who is a champion for driving the change that we need. Dr. James is a consultant for First Year Cleveland and the former associate professor of obstetrics and gynecology and pediatrics at the Ohio State University Medical Center and Nationwide Children's Hospital. And he has spent his career involved in the care of underserved populations, including expanding services to indigent patients, patients using drugs, HIV-positive pregnant patients, and teens, and working with states and communities to reduce infant mortality and eliminate disparities. Among many notable appointments, he founded and served as the medical director for Borges Medical Center's Women's Health Office. He served on the Health and Human Service Secretary Advisory Committee on Infant Mortality and was the former senior policy advisor to the Ohio Department of Health. Dr. James has received numerous and local national awards for his advocacy to achieve equity in birth outcomes, and is a frequent national speaker on infant mortality and national racial disparities. With that, Dr. James, I turn over to you.
Thank you very much, Stacy, and thank you to NICHQ for the contribution you are making to this very important national conversation we're having about equity. So as you can see, the title of my talk is Equity, essentially in the opportunity to survive the first year of life. And for those of us of African ancestry, I would suggest that this is, in fact, a dream deferred. Next slide. Next slide. So by definition, infant mortality is, is the death of any live-born baby prior to his or her first birthday. And of course, it is one of the most sensitive indicators we have for social well-being, not only in the United States of America, but across the entire world. Next slide. Infant mortality also represents what is referred to as a community mirror. So it reflects our collective capacity to promote and protect the health and well-being of our very youngest and most vulnerable. Next slide. Secretary's Advisory Committee on Infant Mortality reminded us back in January of 2013 that the contributors to infant mortality are multifactorial. So that it not only includes what we provide in terms of healthcare, but 2 through 5 in this list representing social determinants are also very important. And then there is this paragraph at the end of the slide that essentially says that our ability to prevent infant deaths and to address disparities is a measure or barometer, if you will, of our society's commitment to the health and well-being of all women, children, and families. Next slide. So with that in mind, I'd like to review some infant mortality data for us nationally. And I'll review it with a consistent set of data that I will look at, but look at various contributions from that, or various characteristics from that data set. Next slide. So this looks at the overall infant mortality rate for the United States from 1980 to 2016, a 37-year period of time during which the infant mortality rate for the United States of America was decreased by a bit more than 50%. And I think we should all be proud of that. That's a tremendous accomplishment. Next slide. When we disaggregate that blue line by Black-white race, we can see the Black infant mortality rate in black at the top line here and the white infant mortality rate in red at the bottom. And of course, the Black infant mortality rate is consistently, significantly higher than the white infant mortality rate. Next slide. So looking at the persistence in this disparity, I'll remind us of that paragraph from the Secretary's Advisory Committee on Infant Mortality, that the persistence in this gap tells us something about our commitment to the health and well-being of all women, children, and families. Next slide. So I want to take a look at three different characteristics of this period of time relative to infant mortality. First, looking at the disparity ratio and what I refer to as the survival interval, and then next, how we've done in terms of achieving healthy people goals by race in this country for infant mortality. Next slide. So here we're looking at the disparity ratio. You can see back in 1980 that Black babies died at 2 times the rate of white babies. Fast forward to 2016, where you see that the disparity ratio has gone up, even though we made improvements in both Black and white infant mortality. And that disparity ratio increases because we've improved the white infant mortality rate at a faster pace than we've improved the Black infant mortality rate. You can see those improvement numbers associated with each of those rates. Next slide. Next, I want to talk about the survival interval or the survival gap. This is kind of a number that I've made up. But the reason for it is because in the previous slide where I've talked about the disparity ratio, when we talk about the difference in Black-white survival during the first year of life, that's kind of where the conversation generally stops. Black babies die at 2 to 3 times the rate of white babies, and we move on. But I think that that gap tells us something much more significant that often we just kind of gleam over. And so here's one of the things that I think it also tells us. Next slide. If you look at our last Black infant mortality rate, or the Black infant mortality rate for 2016 at 11.76 Black deaths per 1,000 live Black births, and then go back in time to find a comparable white infant mortality rate, you have to go back into the late 70s, 1978 to be more precise, to find a white infant mortality rate comparable to our 2016 Black infant mortality rate. That means that we have to go back in time about 38 years to find a comparable white infant mortality rate. And if we don't change this pattern, if the pattern that's been established over the last 37 years persists moving forward, then what this country is saying to people of color, Black people in particular, is that Black babies have to wait until the year 2054 to experience the same opportunity of surviving the first year of life as white babies did in 2016. Next slide. So I think part of our discussion needs to concentrate more, not just on improving infant mortality, but on eliminating this gap. So what do I mean by that? Let's digress for a second and look at the 2 runners on this slide. If our goal is to have the runner who is behind catch up to the runner who is in front, without having the runner who is in front slow down so that the runner who is behind can catch up, then I think everybody appreciates and understands that what we mean is that the runner who is behind has to run faster than the runner who is in front in order to eliminate this gap. If we apply the same where infant mortality is concerned, then the 2 principles outlined on this slide pertain. That we have to get to a point that we improve the Black infant mortality rate at a faster pace than we're improving the white infant mortality rate. And we must accomplish number 1 without compromising the rate of improvement in the white infant mortality rate. Next slide. Now, I've had the opportunity of giving various versions of this talk in 30 of our 50 states. And inevitably, one of the responses to the previous slide is that people say, well, gosh, Dr. James, we can't do that. It would be wrong for us to intentionally work on improving the infant mortality rate for one group of people at a faster pace than we do for another group of people. They complain that doing so would be immoral, it would be unjust, that it would be unfair. Next slide. But in fact, that's what we've been doing in the United States for decades. We've been doing it for decades and nobody's complained. We behave as if the persistence of this gap and improving the rate at a faster pace for white babies than we do for Black babies is normal. And I would like to suggest to you that it is not. Next slide. We also hear from a lot of people that, well, you know, that's pie in the sky, Dr. James. We can't really do that. So I show you these slides that look at Black-white infant mortality by decades from 1950 to 2000, where the white infant mortality rate is represented by the purple bars, the Black infant mortality rate by the black bars, and then there's this blue disparity ratio line. You can see that generally the disparity ratio line goes up because we improve the white infant mortality rate at a faster pace than we improve the Black infant mortality rate. One of the other characteristics of this slide that I want you to appreciate is that we can improve the Black infant mortality rate. On this slide, we generally accomplish a white infant mortality rate for Black babies about 20 years after we've accomplished that rate for whites. But what I want you to appreciate on this slide is the decade from 1960 to 1970, where the disparity ratio decreased. We went through a decade where, in fact, we improved the Black infant mortality rate at a faster pace than we improved the white infant mortality rate. And I'd like to suggest to you that the primary reason for that is the passage of the Civil Rights Act, that it was an act that influenced quality of life, particularly for people of color, that resulted in an increased opportunity of babies surviving the first year of life. Next slide. The next characteristic of the same data set that I'd like to look at is how we have done as a nation regarding the achievement of healthy people goals. Starting with Healthy People 1990 and going to the current Healthy People umbrella that we operate under for Healthy People 2020. Next slide. For Healthy People 1990, we said that by the time we got to 1990, we wanted to have an overall infant mortality rate of 9, depicted on this slide by point A, a Black infant mortality rate of 12, depicted on this slide by point B. We achieved that overall infant mortality rate goal for white babies in the United States in 1984, well in advance of the goal date. Next slide. For Healthy People 2000, we said that by the time we got to the year 2000, we wanted to achieve an overall infant mortality rate of 7, depicted on this slide by point C, a Black infant mortality rate of 11, depicted on this slide by point D. And once again, we achieved that overall infant mortality rate for white babies in 1992, again, well in advance of the goal date. Next slide. For Healthy People 2010, we made some significant changes. We said that in the process of establishing our goals that we wanted to increase the quality and years of healthy life, and that we wanted to eliminate health disparities in 6 healthcare areas, one of which was infant mortality. We were pretty aggressive in establishing that goal, saying that by the time we got to the year 2010, we did not want any group in the United States to experience an infant mortality rate greater than 4.5 deaths per 1,000 live births. Next slide. That goal of 4.5 deaths per 1,000 live births is depicted on this slide by point E. And as you can see, we did not achieve that goal for white or Black babies by the time we got to the year 2010. But what was significant for us in achieving goals in 2010 is that by 2010, we actually achieved the Healthy People 1990 goal for Black babies. So 20 years after the goal date, we were able to accomplish that goal. Next slide. Now, because a lot of people have suggested that, in fact, we cannot improve the Black infant mortality rate at a faster pace than we improve the white infant mortality rate, I've gone back to this article that was released by the Center for Disease Control back in April of 2013, where they looked at trends in improving infant mortality for a period of time from 2005 to 2011. Next slide. Part of what this article highlights is that during that period of time, the Black infant mortality rate improved by 16%, the white infant mortality rate by 12%, Hispanic 9%. My point here is that as a nation, we were able, if you think back to that Running Man slide, we were able to improve the Black infant mortality rate at a faster pace than the white infant mortality rate. Next slide. And as a consequence, when we add 2010 to this decades of data for Black white infant mortality, I bring your attention to what happens with the disparity ratio, that blue line at the top, where you can see that by changing the national narrative, instead of planning for Black babies to die at a significantly higher rate than white babies, but saying as a nation that we wanted no group to experience an infant mortality rate different than another group, that in fact we were able to significantly impact the disparity ratio. We were able to improve the Black infant mortality rate at a faster pace than we did the white infant mortality rate. And I would argue that we did that without compromising the rate at which we improved the white infant mortality rate. Next slide. So for Healthy People 2020, the Healthy People umbrella under which we operate now, we have essentially 16 months left of Healthy People 2020 goals, where we have again doubled down and said that we want to achieve health equity and eliminate disparities. Our goal, as you all know, is that by the time 2020 ends, we'd like for all groups to experience an infant mortality rate no greater than 6 deaths per 1,000 live births. Next slide. And that goal is depicted on this slide by point F. We achieved that goal for white babies in the United States in 1997, 23 years in advance of the goal date. Next slide. So I would suggest to you that as a country, we've established a racially determined pattern in achieving the opportunity for surviving the first year of life. And that pattern suggests that in 3 out of the 4 decades that we've looked at Healthy People infant mortality goals, we were able to achieve our overall goals for white babies, and we were able to achieve those goals in advance of the goal dates. Similarly, after nearly 4 decades, we achieved only one Healthy People Black infant mortality rate goal, and that one was achieved 20 years after the goal date. So those numbers at the bottom of this slide are to remind me when I'm talking to groups to pose the following question. If I ask you to tell me the next number after 2, 4, 6, 8, everybody would say 10. 5, 10, 15, 20, everybody says 25. And we say that with total and complete confidence because we understand that the pattern established by the previous numbers tells us what to expect in the subsequent number. I would challenge you to think about infant mortality and our goals in the same way, because 37 years worth of data establishes a very reliable trend for what we are doing in this country in terms of achieving infant mortality goals by race. Like one of the other slides earlier said, this infant mortality rate is a community mirror. And what Sackham said is that the persistence of these goals tell us something about ourselves. Next slide. So it's led me to pose the following question. Do Black babies in the United States of America really matter? Or to soften the question a little bit, do Black babies in the United States of America matter as much as white babies? Next slide. And while everybody answers this question with yes, I would argue that our actions don't support that response. Next slide. Because despite the data, there's still those of us who believe that the Black infant mortality rate can improve. There are also others who believe that while it can get better, that it can never be as good as the white infant mortality rate. And we persist in suggesting that the reason that the Black infant mortality rate is as high and as bad as it is because of group level flaws amongst those of us who are Black. And some of those characteristics that we hear most often are represented in the periphery of this slide. Next slide. So I show this data slide that looks at 3-year aggregate data from 2011 to 2013. Starts from the worst, goes down to the green, the best. Infant mortality rates in the 4 different categories listed here. Let's concentrate on the Black infant mortality rate column highlighted in yellow. What you will see is that the state of Massachusetts, in green at the bottom of that column, had a Black infant mortality rate of 6.9 deaths per 1,000 live births. That Black infant mortality rate was twice as good as the Black infant mortality rate in Kansas, Wisconsin, Ohio. And so if in fact, the reason that the Black infant mortality rate is as high and as bad as it is because of group level flaws amongst those of us who are Black, then how do we explain this difference in the Black infant mortality rate? Is it because all of the Black people who were the most flawed preferentially moved to Kansas, Wisconsin, and Ohio? Is it because doctors, midwives, and nurses in Massachusetts are smarter and work harder than their counterparts in Kansas, Wisconsin, and Ohio? Is it because the hospitals in Massachusetts are so significantly better than the hospitals in those other states? Or might it have something to do with how we organize life and support families, one state to another? And it has little to nothing to do with personal level, group level flaws that account for the differences between Blacks and whites. Next slide. Healthy Start, now in its 28th year. Remember, to become a Healthy Start project, the area has to prove that it has an infant mortality rate that is at least 1.5 times the national average. And back in 2015, when they looked at the cumulative Healthy Start project infant mortality rate, that rate of 4.8 to 5, I've seen both numbers representing the 2015 cumulative rate for Healthy Start sites. But that number is less than the national infant mortality rate at that time. And keep in mind that during this time, the overwhelming majority of Healthy Start sites were concentrated in predominantly Black communities. So we know beyond any shadow of a doubt that we can do better relative to the Black infant mortality rate. Next slide. So why the disparity? And what do we do from this point? If Black babies matter as much to us as white babies, why do we have this gap? Next slide. I'm going to start by suggesting that our interventions, generally speaking, to improve infant mortality, almost always land in the clinical bucket. So we provide tons of money for clinical interventions, and we pay very little attention to the social circumstances that place families at increased risk for compromised outcome. Next slide. So we describe infant mortality almost entirely in clinical terms. Babies die from preterm birth, congenital anomalies, sudden unexpected infant death, maternal complications of pregnancy, cord accidents, etc. Next slide. I would suggest to us, especially when the conversation involves disparities, that there's a whole nother realm of things that we need to pay attention to. We need to pay attention to this clinical stuff. I don't mean to suggest that we don't. Next slide. But I would like to suggest that the social circumstances that families live in are at least as important as the clinical circumstances we invest so much in addressing. Next slide. I'd also like to suggest that, in my opinion, we make our best decisions for intervention programs in the area of overlap between the clinical and the social. Next slide. So that where disparities are concerned, we have to get to a point that we pay attention to all of this stuff below the waterline in this slide. And as long as we only concentrate our interventions in the stuff in that boat, then we never figure out what wrecked the boat in the first place. We never get to the point of adequately addressing the disparities that occur in birth outcomes. Next slide. I think the World Health Organization has made it pretty clear to us that inequities in health and avoidable health inequalities arise because of circumstances in which people grow, live, work, and age, and that these are in fact shaped by political, social, and economic forces. Next slide. So if I was to draw up how our intervention strategies ought to look, they would probably look something like this, where we would address the social stuff that place families at significantly increased risk for compromised outcome without compromising what we offer in terms of clinical interventions. Next slide. Thank you all very much.
Thank you, Dr. James. Thank you for the wonderful presentation. And I just want to remind everyone that you can put your questions in the chat box. We will address them at the end of the webinar. Now I am really pleased to introduce our next speaker, Ms. Denise Evans. Ms. Evans is the project coordinator for Strong Beginnings Healthy Start program and is a trained facilitator in the areas of health equity and social justice. Cultural intelligence and implicit bias. She has facilitated health equity social justice dialogue sessions for local social service providers for over 8 years, both locally and nationally, and she works closely with Michigan State and local health departments, Michigan Public Health Institute Center for Health Equity, and she also serves as on the National Association of County and City Health Officials, and works with them on their Health Equity Advisory Group. As a Gamaliel-trained community organizer, Ms. Evans uses her experience to provide leadership within the state and local power to thrive movement. She's joining community organizers and public health professionals to build a more equitable future for our nation's poor. With that, I'd like to bring on Ms. Evans.
Thank you again for the introduction, and it's our pleasure to be here with you. I bring you greetings from Strong Beginnings, Healthy Start, staff and partners in Grand Rapids, Michigan. Next slide, please. Strong Beginnings is a partnership of 8 community organizations, because you're going to be asking yourself, who is Strong Beginnings? We're a partnership of 8 community agencies working together to improve the health and well-being of African American and Latinx women, men, and their babies from pregnancy into early childhood. At Strong Beginnings, we seek to promote racial equity and to eliminate the health disparities in birth outcomes between whites and people of color living in Kent County, Michigan. We began our journey in 2001 when we first began receiving federal Healthy Start support. And then in 2004 and 2011, we also added the support of the W.K. Kellogg Foundation, where we were able to double our efforts to focus on the effects of race and racism on the health of the families that we serve. We continue to do the hard work to see that every family has what they need in order to have a healthy pregnancy and ensure that all children and families thrive. So this afternoon, I'll do my best to share some of our findings and best practices. One of the first things that we began to do was build strong partnerships. And I'll begin with a brief historical context and then share some of our best practices in hopes that our journey towards health equity might inspire you and help you to find your next place along this journey towards health equity. Okay, you already went to the next slide. Perfect. So Strong Beginnings serves over 1,100 families per year, and our partners with a range of agencies that provide broad ranges of assistance from the public health arena, which include mental health providers, hospital clinics, and our local health department, Healthy Kent, and our federally qualified health center, along with local colleges and universities that assist us with research, reporting, and so much more. Next slide. Our participants are majority African American and Latinx women and their partners living in Kent County, Michigan. Ideally, they would be in the first or early second trimester of pregnancy and or parenting a child under 4 months of age. Strong Beginnings mothers would be living at or below the poverty level and would be Medicaid eligible. Next slide. Because services for lower income populations are generally subpar at best, we work in care teams, or as Dr. James put it, we are linking the clinical and social in teams that consist of community health workers or CHWs, nurses, and as needed or requested, the teams might also include a male community health worker to work with the father or male partner of our mom and an appropriate mental health therapist. Many of our community health workers were former program participants, which we have found immensely positive as it lends greater understanding of the need for the different types of peer support. But who are able to model our program successes. So speaking with intimate knowledge with our client base around the different aspects of our programming based on their own personal experiences. Next slide, please. Our therapeutic services include crisis management services via individual and group therapy, and most of those services are provided in-home in an effort to remove barriers to optimal service utilization and the stigma in some communities about seeking mental health services. Many of our families are dealing with high levels of stress and may suffer from postpartum depression, schizophrenia, or post-traumatic stress syndrome or stress disorder. They may be bipolar and it may be suicidal. Also, our ability to provide services in-home or at a place of their choosing is critical to the successful execution of their care plan. In the current climate in the U.S., we are also seeing an increase in the levels of stressors amongst our Latinx clients, with the added nuances and stresses associated with the assumption of immigrant status and the fear of being picked up or harassed by immigration workers and the trauma that's associated with that. Next slide. Through our fatherhood initiative, we're able to provide many services similar to the support that we offer to our female clients, with the addition of services like 24/7 Dads curriculum, which is used across the country, and providing Friends of the Court amnesty days. At one of our last Friends of the Court clinics, we were able to facilitate the removal of 130 bench warrants, which enable fathers to remain free from the court system sanctions that might include jail time and the removal of driver's licenses, where the consequences would likely result in the loss of work, possibly even their housing, and their ability to be present for and support their loved ones and children financially as well. So we continue to work diligently to promote and facilitate healthy co-parenting environments and work with both parents together when possible. Next slide. In similar fashion, Strong Beginnings provides education classes within our community. We offer these options for other service providers, community residents, that may or may not be a part of our program. In addition to what's listed on the slide, we provide education about safe sleep, intimate partner violence, dating, postpartum depression, co-parenting, and many other topics that affect the more than 3,500 individuals that we serve annually. Next slide. Based on a 3-year quasi-experimental design study using vital records and state administrative data, the records showed that our clients are those at a greater than average risk of adverse health outcomes. So what does that mean? Well, when compared to other African-American pregnant women on Medicaid in Kent County, Strong Beginnings clients are more likely to be unmarried, live in extreme poverty, and have unplanned and often unwanted pregnancies. They're more likely to smoke cigarettes and use marijuana. They're more likely to be in unhealthy and abusive relationships, be clinically depressed, and more frequently be homeless at some point during their pregnancy or the child's first years of life. And they may have had even a prior poor pregnancy outcome. Next slide. Based on data gathered from vital records and administrative data from MDHHS, published in the American Journal of Public Health, because of the extraordinary care coordination that Strong Beginnings is able to offer, we're able to document that our mothers and babies on average have pregnancy outcomes that are better. On average, our clients were more likely to have higher rates of first trimester prenatal care, adequate and better than adequate prenatal care, and have almost 15% higher rate of attending both their postpartum exam and keeping their children's well child visits as we walk alongside them to secure services and to address the social determinants of health, which is something that we're extremely proud of and privileged to do. Next slide. In another quasi-educational study over a 7-year period beginning in 2009, using only Strong Beginnings clients enrolled in the first or second trimester and using 5 different propensity score matching methods, we discovered that our participants had significantly lower rates of preterm birth and very preterm birth than the matched non-Strong Beginnings counterparts. Next slide. It's been proven that infant mortality, low birth weight, and preterm birth are not medical issues. They are social issues that have adverse medical consequences. We understand and we help to spread the word that personal responsibility and blaming families living in vulnerable communities is not the reason for these poor health outcomes. We know that only about 30% of a population's health is based on unhealthy behaviors, such as tobacco and alcohol use, diet, exercise, and safe sex practices. Another 20% of a person's health status, as depicted on the slide, depends upon their access to medical care, the quality of that care or the lack thereof, and or the lack of insurance altogether. And 10% has to do with a person's physical and even built environment, while the remaining 40% is based upon the social and economic factors like education, employment, and income, discriminatory factors, family and social support, and community safety. Next slide. Efforts to address those factors are being addressed through the Infant Health Action Team, part of the work of the Healthy Kent, part of the Healthy People Initiative, and it serves as Strong Beginnings Community Consortium for local systems work. Over the last decade, the IHAT, as we call it, has grown to 90 members on 12 committees addressing various factors related to maternal child health. Over the last decade, that IHAT team has grown to over 90 members on 12 committees addressing various factors related to maternal child health. I was saying that it would take about 2 full hours to describe their work, but they have been successful in helping to get some changes implemented in our public transportation system in Kent County, helping to get transportation millage passed. And we've also created some simple tools to help providers screen for and refer patients on for non-medical psychosocial services that include things like emergency food, intimate partner, and mental health supports. And the drug-exposed infants group was successful in getting most of the hospitals and clinics in the Kent County area to adopt universal drug screenings that utilizes a standardized tool. Next slide. With that, I'm reminded of this tool that helps to ground our understanding of the families that we serve. And it's a resource from the 2009 documentary that hopefully all of you have seen by now, Unnatural Causes is Inequality Making Us Sick? And a few that I'd like to highlight for emphasis are simply that health inequalities are unnatural. As Dr. James even stated earlier, health is more than healthcare, and the choices that we make are shaped by the choices we have. Chronic stress can be toxic, and then finally, racism adds and imposes an added health burden. Next slide. So Dr. James so eloquently covered what accounts for disparities in his slide deck, but I'd like to reiterate is that it's easy to think of personal responsibility or possibly poverty, education, income, and zip code. However, research going back over 20 years shows us otherwise. Poverty, limited education, substance abuse, and other factors impact birth outcomes, but they do not explain racial disparities. In other words, it's not being Black or Latinx that puts people at risk. It's how people are treated by society for being Black or being Latinx. And it's the generational effects of stress and the predisposition to have higher levels of stress hormones passed down from mother to baby in utero. And just for clarity, as it's written here, that research indicates that it's the chronic stress of a lifetime exposure to racism and discrimination. The term racism here is including all forms of racism, personally mitigated or individual, systemic, and internalized racial oppression. Next slide. This information is heavily supported and based on Dr. Michael Liu's work on the impact of racism on birth outcomes and the life course perspective framework that I'm sure many of you are also familiar with. With that as a backdrop, we at Strong Beginnings and in the Healthy Start family believe that racism compounded by growing inequities in wealth and income is the root cause of health disparities, which includes disparities in birth outcomes. We further believe that there are basically 3 manifestations of racism: individually mitigated, institutional, and those that are internalized, all of which produce high levels of chronic stress. Next slide. Stress also produces physiological changes, which include the release of stress hormones such as cortisol and adrenaline, that are known to affect and raise blood pressure, decrease blood flow to the placenta, and suppress immune systems and increase susceptibility to infections like UTIs and STIs. And we knew that we had to do more. Next slide. Our team recognized that working with local initiatives was great and it was helpful, but we needed to see and be a part of other initiatives and what was being discovered in neighboring cities within our state and also within our nation as a whole, and began to work with several agencies, community groups, coalitions, consortiums, statewide efforts to glean from them and share best practices. And on the screen are a number of them listed. Next slide. As a result, we began to bring some of the information home to Kent to compare and contrast findings, and we realized that there is truly nothing new under the sun, and we wanted to find new and exciting ways to raise awareness within our entire community, with the goals of fostering organizational culture and community environments for advancing health equity and incorporating health equity and diversity in public health programs, services, and policies. We started very simply with a series of lunch and learns for area social service agencies to help educate us on issues that were plaguing some of our most vulnerable communities. And if you notice, we don't say of our most vulnerable people, but it's the communities and the way that they have been situated that becomes the problem, not the individual themselves. So in 2009, as I mentioned a little earlier, we introduced unnatural causes, and we began to show that in community. And then we, in 2015, began viewing a series entitled The Raising of America. And for us in Kent County, we began this process after an article in Forbes magazine cited Grand Rapids as one of the best places to raise a family. Shortly thereafter, within 6 months, another article was released stating that Grand Rapids was 52nd out of the 53 worst cities for African Americans economically. Quite a contrast, huh? Last year, we began showing another series entitled America Divided. And we showed this series to over 600 people per viewing and for the larger community. We additionally wanted to increase our community capacity and provided train the trainer sessions for approximately 30 individuals representing 12 agencies. And we're able to replicate efforts and have much more of a broader reach into different areas of discipline. So we hosted community residents in the evening and provided meals and a children's movie and childcare. And during the day, we provided the same series for area professionals who are working with the populations that we serve. So the way that we continue to educate today is that we continue with our health equity and social justice dialogue workshops since 2012. We had done some series of educations entitled Expanding the Boundaries of Health Equity and Public Health Practice, and we began that in 2015. In 2016, we started partnering with NICHQ on a Kellogg initiative entitled Healthy Heartlands Building Bridges for Equity, which now has become what we're doing more locally as the Michigan Power to Thrive movement. And the two areas of focus initially were on mass incarceration as a health crisis and ensuring funding for early childhood initiatives. In 2017, we added unconscious bias and implicit bias training. And just last year, in 2018, we began offering Health in All Policies Learning Labs. Next slide. Based upon some of our work with partners, as mentioned, we began to engage in more research and spoke about implicit bias in healthcare. One study that we examined revealed that implicit bias in doctors made them more likely to prescribe effective drugs to white rather than Black patients, and that's cited at the bottom of the slide. Doctors were presented with case studies of symptoms and asked to make recommendations for treatment prescriptions, and they were more likely to prescribe the effective drugs to white rather than Black patients. So with some of this in mind, we decided to do some research on our own client base. Next slide. In 2015 and 2016, we worked with researchers out of MSU to facilitate a number of focus groups with clients, and we published our findings in a 2017 article in the Maternal and Child Health Journal entitled Understanding Perspectives of African American Medicaid-Insured Women on the Process of Perinatal Care and Opportunity for Systems Improvement. Some of the things that were lifted up in the sessions as I was facilitating them were things like providers assuming that mothers of color can tolerate pain, so they were offered fewer pain medications in labor and delivery. Providers assume that patients don't care about delivery options, excuse me. And so they were surprised when mothers would ask about doula services, midwifery, or water births. And so we can go to the next slide. Some other things that came up for our clients were if they were Hispanic or Latinx looking, they were asked questions in a raised voice like, do you need an interpreter? Being concerned about receiving birth control injections in the delivery room without consent was another high concern for many of our clients. All of these things which produced very high levels of stress in those that we served. Next slide. Next slide. Stereotype threat is another one that came up, and I'm sure you have questions about how you can engage in some of this work. But stereotype threat includes things like concern when showing up for a prenatal visit without a male present, or being asked whether or not her children all have the same father. All of these things produce high levels of stress. So how can you engage in this work? I'm glad you asked. There are some approaches. Yes, there are approaches that we have identified to infuse us in the work of health equity and in birth outcomes. One, we wanted to provide equity training that considers social, economic, and environmental factors that impact health. Another is to standardize data collection and analyze the data by race and other factors. Another is to allocate resources to support equity, and that can be in can be used in new or revised programming. Next slide. What we found the need to do was require staff to study our nation's history, to allocate resources as an organization to support implicit bias training and other types of training, make sure that we maintain, or you maintain, a community action network so we can hear what's happening on the ground, be involved in local racial healing work, and dedicate staff time to leading the work. Next slide. In conclusion, we believe that until we tackle the underlying issues of racial inequities and social injustice, we will not eliminate health disparities. We have to foster a communal sense of social responsibility, just as we do for personal responsibility. And then finally, racial equity will not be achieved overnight, but we have to be committed to improving maternal-child health through social justice and community engagement. Next slide. We believe that all of the forms of inequality and injustice, of all of them, healthcare is the most shocking and the most inhumane. So thank you so much for your time.
We are right at 2 o'clock, and I recognize that it's supposed to be an hour, but we're just going to go over a few minutes. There's a lot of questions that have been posted in the chat box that I see Dr. James have been responding to. And if you have to get off, we understand. This will be recorded, and we will send the link out. When you look at teen pregnancies, does the same infant mortality rate disparities exist between Black, Hispanic, and white mothers? I'd like to open that up to both Ms. Evans and Dr. James, if you all have an answer for that question.
When we look at the incidence of teen pregnancies, we note that there's been a significant decrease in the incidence of teen pregnancies in our country over the last few decades. Where disparities in terms of outcome for those pregnancies are concerned, yes, there still is a disparity, particularly between Blacks and whites. I'm not sure about between Latinos and other groups, but it certainly is an area where we need to continue to focus on and make improvements.
Okay. All right. So with our next question, we would love to hear more about the fatherhood engagement and how you set up what the benchmark for that. And that's probably for Ms. Evans, if we haven't lost her.
Hopefully you can still hear me.
Yeah, I can hear you. Go ahead.
All right. We realized, and this is also indicative of our Healthy Start initiative, that the father has often been dismissed for most of the programming services. And so we knew that we needed to add dad back into the equation in a very intentional way. So most of our services mirror On the father's side, many of the things that we do on the mom's side, so reproductive life planning, all those things we also do with the father. Now, the question was specifically about benchmarks. Is that correct?
Yes. It's kind of how did you set up the benchmarks for the fathers?
Right. That is something that we are still currently working on because it has been very difficult to maintain fatherhood engagement because, again, as I mentioned in the presentation, we provide the services to a male figure that is in the life of the child. So it can be the grandfather, the brother, uncle, neighbor, current boyfriend, or husband, whatever the situation is. So that's something that we're still working on, but I'd be willing to pass some information on to you or whoever the question went to so that we can share that more broadly at a later time.
Okay. I want to let everybody know that we have all of the questions that you all sent in, and we will be preparing a document that will answer those questions along with the questions that were in the chat box. I don't know if everybody had an opportunity to see them, but I saw that Dr. James did respond to a few of those as well. What I want to do, though, I mean, we could definitely continue, but I want to give Dr. James an opportunity to talk about his upcoming conference that he's having in Cleveland, Ohio, before everybody leaves the line. Can you move to the next slide and allow Dr. James to talk about that?
So on November 8th and 9th, thank you, Stacy, for this opportunity, by the way. On November 8th and 9th in Cleveland, we are having a 2-day conference in which we are doing several things. First off, we are in the year 2019. For those of you who are not aware of it, this year represents the 400-year anniversary of African-American slavery in the United States. The first Africans were brought here and enslaved in 1619. Unfortunately, our country established a commission for commemoration of this history, but this administration did not provide that commission with any funding. And so the first part of this summit that we're planning is to commemorate that history. The second is to help people understand the connection between that history and how the United States of America has managed race and the disparities that we experience today. It's my belief, as you've heard throughout this presentation, that these disparities are not natural. They are man-made. We created the conditions that have resulted in these disparities, and it's important that people understand and appreciate that. It will be part of what we talk about during this summit, and then, of course, conversation for where we move beyond this. Some of the speakers we will have here will include John Powell, Dr. Harriet Washington, Dr. Derek Hamilton, Jason Reese, Monica McLemore, Jenny Joseph, Joya Career-Perry. So some pretty substantial, high-thinking folks. Stacy Stewart, President and CEO of the March of Dimes, Dr. Gail Christopher will all be presenters at this conference. And the website is listed here on this slide, and if any of you have the opportunity, we would really appreciate your attendance. Whether or not you can attend, please help us to spread the word, because we think this is going to be a very significant and influential meeting. Thank you.
All right. I want to do one last question, and I want to thank everybody for your patience. We are so sorry for the technical difficulty, but the weather was nothing that we can control, but we will definitely again be sending this link. I just want to pose a question to Ms. Evans. How do you find your clients? How do you make sure that the women most in need are aware of your services?
Well, that's a great question. Hopefully you can still hear me.
Yes.
We do a lot of community canvassing. We are at most, if not all, community events that we're invited to or hear about. We provide tables. We go into barbershops, hair salons, hospital, clinics, you name it, we find ourselves there. And we build relationships within the community over a plethora of different areas. So we're not just in the clinical space, where we are where people are. And we build trust on all of those levels. We provide focus groups, listening tours, we go to churches, and are engaging folks in every possible arena around pregnancy and childbearing and during childbearing years.
Okay.
And
All
we have
right.
a community consortium that is made up of community residents. I'm sorry.
Oh, no, that's fine. I am going to say at this particular time, again, we would like to have gone into more questions, but trust me, we have captured the questions that you have submitted. We will be sending out a response to those questions. And I just want to take this opportunity to thank both Dr. James and Ms. Evans for taking out their time today and with us on the webinar. It's never enough time. Thank you so much for your contribution as we work toward establishing health equity. Who knows, we might bring back together again real soon. So with that, I'd like to thank you, and I'd like to thank all the participants for your patience. And we're going to close the webinar out now. Thank you.